Hello, and welcome back to another lecture video. My name is Carlos Prime Francia, and today we're going to be learning about the heart, the anatomy of the heart, and the circulation pattern of the heart. The heart is an amazing pump. It starts beating when you're first forming in the womb, and it doesn't stop beating until the day you die. And right here, we first start at the right atrium. So some basic anatomy. These little walls that you see here are the atria. This guy right here too. And this large ovular shape is called the ventricle. You have the left ventricle right there with the veins and the arteries, and you also have the left ventricle. The very point at the heart is called the apex. And what happens here is that in the right atria, we receive venous return from the superior vena cava right here, and we also have the inferior vena cava. The vena cava are just very, very large veins that return blood that is deoxygenated into the right atria. And I think it's better if you actually see the atria hollowed out. So I'm going to kind of carve out the heart, and you can see the interior of the atria and the ventricles. So now we see the hollowed out portion. The heart has two upper lobes. These are called the atria. So singular is atrium and plural is atria. We have the right atria and we have the left atria. Now the right atria will have this little weird appendage right here on this section. And what that is called an auricle. So that is an auricle right there on this section. So the right atrium has this little auricle that you can't see. And auricle is just kind of like the little appendage that swells up with extra blood. So whenever you're exercising, more venous blood will come into the right atria, and this little upper portion of the right atria will swell up to accumulate or to accommodate that extra blood flow. The same thing is present within this little ear-like structure called the auricle of the left atrium, and we'll talk about him later on. But what happens here is that deoxygenated blood from the head and the shoulders and really the upper arms, those go from the superior vena cava. The venous return from the lower body, like the diaphragm and lower, that returns up to the heart via the inferior vena cava. And the right atria takes in that blood and it shoots it into the ventricle. And you're probably wondering what this little hole is. What this little hole is called, it's called the fossa ovalis of the right atrium. And what is the fossa ovalis? When you were forming in the womb, the heart of the infant had kind of like a little shortcut between the right atria and the left atrium. And we had that shortcut because we weren't using our lungs. Instead, we were using our mother's lungs for oxygen. And so the blood will go into the right atria and shortcut into the left atria. And that was called the foramen ovale. And this little hole had a flap, and that's called the septum primum. Septum just means wall. So right here we have the septum between the right ventricle and the left ventricle, and we call that the interventricular septum. Inter means between, ventricular septum, wall, between ventricle wall, interventricular septum. So here we had on the right atrium, we had the little hole called the foramen ovale. Now it's closed up and it's called fossa ovalis. Kind of like fossil, it's just really old, it's a remnant. And there was once a little flap, and we called that the septum primum. But now it's been closed. But anyways, the blood pulls into the right atrium, and then it pushes into the right ventricle. And notice that we have this weird looking gate. This weird gate is actually an atrial ventricular valve. So an atrial ventricular valve. And specifically, this is called the tricuspid. And the reason why we call it tricuspid is because there are three flaps. If you notice, there's 1, 2, and 3. 1, 2, and 3. So that is a tricuspid valve. Similarly, there's an atrioventricular valve between the left ventricle and the left atria, and it's a different name. So notice if we zoom in, we notice that there's only two flaps, and we call this a bicuspid valve. Bi means two, and in clinical knowledge, well, we don't really say, oh, you have a bicuspid valve prolapse. No, we call this a mitral valve. And so there are two names. There's the bicuspid valve and the mitral valve. Similarly, we also have other valves. So in this big trunk right here, in this big trunk, we have the pulmonary trunk. So this big trunk goes into the lungs, but notice that there's this weird valve to it. And this weird valve is called the semilunar valve. And the same one can be seen if we go over here. If we go on the left atria and we look upwards, we also see another semilunar valve going into the aorta right there. So notice that this goes into the large ascending aorta. And that's just so that blood doesn't prematurely go into the lungs or into the pulmonary cardiovascular system. And these valves also prevent the blood from going back into the ventricles once they leave. And the reason why is because when blood goes past the semilunar valve, if we can zoom in, there's these little pockets. And the blood, as it exits, it starts to push back on these pockets, which close it shut very tightly. And that's why you don't have any, well, hopefully you don't have any blood going back into the ventricles once they shoot the blood into the pulmonary trunk or the aortic arch. So that's valves. So again, to recap, superior vena cava, inferior vena cava, the blood goes into the right atrium, it flows past the tricuspid valve, and it goes into the right ventricle. From the right ventricle, the ventricle squeezes the blood and it shoots into the what? Into the pulmonary semilunar valves. From the pulmonary semilunar valves, it goes into the lungs. So let's get a picture of the lungs. Here we have the nice heart and lungs. And now that we just left the right ventricle shoots the blood into the pulmonary artery. So here are the pulmonary trunk and the pulmonary semilunar valves. And right here, we're going to be looking at where this pulmonary trunk shoots the blood into. So right now, if we look behind the heart, we notice that this little trunk, this pulmonary trunk, splits into two large arteries. So you're probably saying, hey, Brian, we were taught that arteries always go away from the heart and they always carry oxygen that is rich. You know, we carry blood that has oxygen. Well, yes, but in this case, we have the exception. Notice that these arteries are going away from the heart, but they are deoxygenated. So they're going into the right pulmonary system and into the left pulmonary system, respectively, so that they can get oxygen from the lungs. So we have deoxygenated blood in the pulmonary arteries, and they go into the lungs. We go from the arteries into the pulmonary veins, and the pulmonary veins into the capillaries, and when you have the pulmonary capillaries, that's when you slow down the blood flow and you give the blood time to take in oxygen from the lungs. And when that happens, you now go from deoxygenated blood to oxygenated blood. But how does that blood return to the heart? Well, now the blood coming back from the pulmonary system, that's going to be transported to the heart via the pulmonary veins right here. And here, again, we have the exception where normally veins carry deoxygenated blood. The pulmonary veins will instead carry oxygenated blood to the heart. And specifically, they go into the left atrium. So to recap, superior vena cava and inferior vena cava, they shoot venous blood that is deoxygenated into the right atrium. The right atrium will shoot that blood past the tricuspid valve into the right ventricle. The right ventricle will squeeze that blood that is still deoxygenated into the pulmonary trunk past the pulmonary semilunar valves. the pulmonary trunk will shoot that blood into the pulmonary arteries, which is deoxygenated blood. It goes into the pulmonary system and it gets oxygen, and then the oxygen goes from the pulmonary system into the pulmonary veins. Now the pulmonary veins are oxygenated and they go into the left atrium. From the left atrium, we have this little atrial appendage, and this is called the left auricle. And now the left atrium will squeeze again in unison with the right atrium, and it's going to squeeze past this bicuspid valve. Bicuspid because we only have two little flaps right here, two flaps instead of three. And it goes into the left ventricle, and the left ventricle squeezes, and now it's going to push this blood, right here all the way up here to this other semilunar valve. And this right here is the aortic semilunar valve. When this happens, the oxygenated blood is going to go into the aorta, the aortic arch, and is going to go into the systemic system, the systemic circulatory system. And it goes to the rest of the body, like the arms, the legs, the head, etc. And that itself is the circulatory pattern or route of the heart. And now we'll be doing a deep dive into the anatomy of the heart. So again, here we have the right atrium, and the right atrium receives blood. It's going to shoot it into the tricuspid valve. But notice that this tricuspid valve and also the bicuspid valve have these little spiderweb looking things. And really they kind of look like cords or tendons. And so we call this the chordae tendineae. Chordae tendineae. Chordae tendineae. What do they do? What they do is that they keep the valves closed. So when the ventricles contract, the blood that is shooting into the semilunar valves will apply pressure to the chordae tendineae, and it keeps these valves closed because you don't want any of the blood that is supposed to be going into the pulmonary trunk or the aortic arch to be escaping back into the right atria. If you do that, you have a prolapse or you have regurgitation. In fact, a mitral valve prolapse, that's just really a bicuspid valve prolapse, that's when some of the blood from the left ventricle goes back into the left atrium, and you can hear it in a stethoscope, and it sounds like kind of like when you're auscultating somebody. That's what it sounds like, and it's very common. And so you might have people, most likely women, it's very prominent in women, with a mitral valve prolapse, and that causes anxiety, a clinical anxiety. So a failure of the chordae tendineae, either in the tricuspid or the bicuspid valve, will cause a prolapse, and that's really bad. Now these little chordae tendineae are attached to little muscles on the ventricular wall, and these guys are called papillary muscles. These guys are called papillary muscles right there, right here. So on the right ventricle, we're going to have three different types of papillary muscles. Now this papillary muscle is attached to the wall of the ventricle, and this is called the septum. It's really just the wall. The septum is the wall between the left ventricle and the right ventricle. So since we're attached to the wall, we're going to be called a septal papillary muscle. Septal papillary muscle. And here we have two papillary muscles right there. This one is on the bottom, and we call this inferior papillary muscle. And this one is called the anterior papillary muscle, since it's kind of facing towards the front of the heart. So this guy right here is the anterior papillary muscle. And here we have the moderator band. This is the moderator band. And so it's going to attach one septal wall to the other septal portion of the right ventricle. So this is the moderator band. And it just helps the heart keep its tone, its shape as it contracts. And also there are some nerves. When we get into nerve conduction, there are some nerves that go from here to this place. So some nerves travel within the moderator band, and it helps the heart contract as one unit. And notice that this moderator band is not present within the left ventricle. We also have these papillary muscles within the left ventricle. So if I get a better angle right here, we have 3 different types of papillary muscles. And really, these little trios right here, these are the inferior papillary muscles. So they're at the bottom. And therefore, this little spider-looking thing is actually another papillary muscle at a better angle. You have the superior papillary muscles. And again, these guys just help the chordae tendineae stick close when the ventricles contract. So the ventricles will pull on these papillary muscles and shut tight these little valves. And you're probably wondering, well, why do we have these little spiderweb looking things on the septal walls? Why is this here? Well, it's here because a lot of scientists and physicians, they have a theory in which when the ventricles accept blood from the right atria, there's a sucking force. And that sucking force would be really bad for blood flow if the walls were smooth. So kind of like it's physics related, but you don't want any sucking force because that increases the amount of turbulence, the amount of blood turbulency inside the heart. Basically, you don't want the blood to be shaken and stirred as it goes from the atria into the ventricles. And so these little trabecular, well, they're called trabeculations, I guess. These little spider weave things on the septal walls prevent the blood from being stirred too much, and it keeps everything flowing nicely. So now I want to talk about the clinical importance of the left auricle. So why should we care about the left auricle, the left atrial appendage? Well, typically when the left atrium receives blood from the pulmonary veins, it will kind of go into the appendage right here, the auricle, as a reserve. So it swells up and then it shoots that blood back into the left ventricle. So it's going to shoot this blood into the left ventricle. It's kind of like as an extra holding space. But sometimes that blood kind of pools at this little peak right here. And when it pools, it has a chance of coagulation, it has a chance of hardening. And when you have coagulated blood going into the left ventricle, we have a chance that this coagulated blood can go into the systemic circulation. And if it goes into your brain or into the neck or wherever it goes, that little piece of coagulated blood can block blood flow and cause tissue death. So if we have tissue death at the head, where the brain isn't getting enough oxygen, you can have a stroke. So a lot of strokes happen because there is some coagulation of blood within the left auricle, the left atrial appendage. So there is a procedure called the Watchman procedure, and the Watchman procedure is the insertion of a device that will block this little tunnel that you see here, this little crevice. It's like a little parachute, and it's going to cover this hole so that this whole extra storage room is blocked off, and there is no chance of further blood coagulation or pooling of the blood from the left atrium. And that device is called the Watchman, and it's created by the Boston Scientific Corporation. And now we're going to be watching a video created by the Boston Scientific Corporation explaining what the Watchman procedure is and how it can reduce the chances of strokes.
This is the Watchman implant, a one-time procedure that may reduce your stroke risk for a lifetime. If you have non-valvular atrial fibrillation, or AFib, not caused by a heart valve problem, and need an alternative to blood thinners, the Watchman implant could be right for you. AFib increases your risk of having a stroke. In fact, on average, a person with AFib is 5 times more likely to suffer a stroke than someone with a regular heartbeat. That's because AFib causes your heart to beat irregularly, which affects its ability to pump blood normally. And when the heart doesn't pump as it should, blood can collect and form clots. If a clot escapes, it can cut off blood supply to part of the brain, causing a stroke. In people with non-valvular AFib, blood clots most commonly form in an area of the heart called the left atrial appendage, or LAA. Closing the left atrial appendage is an effective way to reduce the risk of a stroke in people with non-valvular AFib. The Watchman implant fits right into the LAA, completely sealing it off so blood clots can't form there and lead to a stroke. The Watchman implant permanently reduces your stroke risk without the use of blood thinners and the worries that come with them. If you take a blood thinner, you are likely aware of the bleeding risks that come with it. Most people can take a blood thinner for years without serious side effects. But because blood thinners help prevent clots by thinning the blood, they also increase the risk of bleeding. Sometimes bleeding can be serious or even life-threatening. For instance, you may experience internal bleeding or bleeding in the brain, which can cause a stroke. If you've experienced this kind of bleeding while taking a blood thinner or think you're at risk for this kind of bleeding in the future, talk to your cardiologist about the Watchman implant. The Watchman implant procedure is safe and minimally invasive and doesn't require open heart surgery. With 20 years of clinical trial and real-world experience, including 10 clinical trials, the Watchman implant has a proven safety record. Similar to a stent procedure, your doctor makes a small cut in your upper leg and inserts a narrow tube, then guides the Watchman implant through the tube into the left atrial appendage. The procedure is done under general anesthesia and typically takes as little as 30 minutes. People who get the Watchman implant usually stay in the hospital for a day or less. After the procedure, your doctor will prescribe you a choice of either antiplatelets or blood thinners. During that time, your own heart tissue grows over the Watchman implant to form a barrier against blood clots until your left atrial appendage is permanently sealed off. Many people may be able to stop taking blood thinners immediately after the procedure, and in a clinical trial, 96% of people were able to stop after just 45 days. Make sure you talk to your doctor to understand the right medication for you and how long you'll be on them after your procedure. The Watchman implant is the #1 doctor-recommended left atrial appendage implant, and it can be a life-changing alternative to the daily use of blood thinners and the bleeding risks that come with them. Get your customized doctor discussion guide so you can talk with your cardiologist about whether the Watchman implant is right for you. Go to watchman.com/guide.
Now, this isn't really talked about in books, but I had known a man who was a patient of ours, and he had the Watchman procedure and he tolerated it pretty well. However, whenever a person does have the Watchman procedure, you want to keep them on aspirin. And that's just for precautionary measures and just for daily maintenance. So 81 milligrams of aspirin a day is really required for individuals who had the Watchman procedure. So yes, you can stop using your Plavix or your warfarin, but we still need that aspirin. And again, when you're checking for warfarin, the INR should be between 2 and 3. And usually every once or 2 weeks, you would get that INR checked, and it's a hassle for these individuals, or sometimes they bleed easily on warfarin compared to aspirin. And so these individuals would be really good candidates for the Watchman procedure when they just can't tolerate warfarin or any really hardcore blood thinners. So that's when you would do the Watchman procedure and recommend aspirin, 81 milligrams a day. Now I want to talk about the pericardial sac of the heart. So this sac wraps around the perimeter of the heart, and it's called the pericardium. Again, peri means perimeter and cardium means heart. And why we have this little sac is because when this heart is contracting, it's going to be rubbing against the pulmonary system, the lungs. You don't want the lung tissue to be scraping the sides of the heart. That's going to be irritating and is going to cause cellular damage. This also prevents the heart from moving side to side too much. That doesn't really happen a lot, but it's really for the protection of the heart. Now, this external sac right here, it kind of looks like a little sleeping bag for the heart, or a sock. That's called the fibrous pericardium. So again, it's kind of bumpy and it looks firm. So we call this the fibrous pericardium. And again, this external sac is called the fibrous pericardium. And if we actually move it, we have a bottom layer. So the next layer after the fibrous pericardium is going to be called the parietal layer or the serous layer. So parietal just means attached. So this attached layer to the fibrous pericardium is called the parietal layer, or also the serous layer. So here is the serous layer right there. It's like a little smooth layer. Now, one important thing to note is that after we kind of take away the parietal layer, we have a layer of fluid. And that layer of fluid is not shown here. But under that layer of fluid is something that we call the visceral layer of the pericardium. So the viscera is the meat. So your viscerals are your organs, your intestinal system. Here, the visceral layer is directly attached to this heart. So this is a very sensitive membrane, so we put fluid on top of that, and then we're going to layer the parietal layer of the pericardium on top of the fluid. So there is no direct contact between the visceral layer of the pericardium and the serous layer of the pericardium. The serous layer, again, is going to be under the fibrous layer, which is the toughest exterior portion of the pericardium. Now, under this visceral layer is the adipose tissue, kind of like the little fat or cushioning for the heart. So here we have that little epicardial adipose tissue. If we hide that, we have the direct contact of the heart. So this is the right ventricle wall. So here we have the membranes of the heart. We have the most external portion of the pericardium, and this is called the fibrous pericardium. That's the external portion. After the fibrous pericardium, we have the parietal layer of the pericardium. So this is the parietal layer. Now we have a gap between the epicardium and the pericardium. So this epicardium right here is going to have this blank space. Normally that space is filled with fluid, and that prevents the epicardium from touching the pericardium. So the epicardium, the other name for this, is called the visceral layer of the serous pericardium. So the visceral layer of the pericardium, if you want to be fancy with it. Now, there is a condition in which this fluid will enlarge. It will actually gather more and more fluid into this space. And when that happens, you're going to have cardiac tamponade. So this is cardiac tamponade. And actually, let's pull up a picture of cardiac tamponade. And so here we have cardiac tamponade, and that is when the fluid starts accumulating within the pericardium. And when you have fluid accumulating within the pericardium, that fluid pushes on the heart. So now when the ventricles try to contract and pump blood into the valves right here, it can't do it efficiently. It already has pressure applying to it by the fluid on the pericardium sac. And so that prevents the heart from swelling up to its full potential and releasing that blood with a nice contractile force. Since you already have pressure on the heart, the ventricles cannot build up as strongly, and they weakly push the blood into the pulmonary trunk or the systemic circulation. And that can lead to really, really bad cardiac complications. And the way to alleviate this cardiac tamponade is to actually cut a little window right here. Just cut it. And we call that a fistula. So we call this a fistula, which is a small opening within the pericardial sac, and that allows some of the fluid to drain out of the pericardial sac. And this right here is actually called a pericardial window. It seems primitive. If you have something that's building up fluid, you just kind of leak out the fluid. I mean, typically you would do the window a little lower so all the fluid drains out, not that high, but anyways. Now, a pearl of wisdom: if you ever see somebody with cardiac tamponade, never ever give heparin. Because that is going to cause massive heart failure in like less than 10 minutes. If you ever give anticoagulants like heparin to a person with cardiac tamponade, that will dangerously harm the patient. So never give heparin to a person with cardiac tamponade. Let's say that you want to be a brainiac, or you're on a date and you want to impress your date with some medical knowledge or something. You can say, well, hey, did you know that the lubricating fluid within the pericardial cavity is made from simple squamous epithelial cells? Specifically, it's actually the mesothelium. And the mesothelium secretes that lubricating serous fluid within the pericardial cavity, and it prevents the muscle of the heart really from rubbing against the external sac of the pericardium. So we have this little myocardium, and again we're going to have this endocardium. So what the myocardium is, it's kind of like the muscle itself of the heart. So this muscle right here is called the myocardium. And what lines the myocardium is called the endocardium. And the endocardium is also made from simple squamous, we're just going to call it SQ, epithelial cell. So directly touching the muscle of the heart is the epicardium, and then past the epicardium is the pericardium. So the myocardium is the muscle, myo is muscle, and the endocardium is what touches that muscle. It lines that muscle. And if we notice here, this myocardium is a little thicker than the right side of the ventricle, because the left side of the ventricle has to pump this blood further into the systemic circulation. So left ventricle has to pump further into the systemic circulation. However, the right ventricle and the left ventricle, they're going to pump the same amount of blood. So let's say that we both pump 80 milliliters of blood. So we have 80 milliliters right here, we have 80 milliliters right there. The right ventricle is going to pump this 80 milliliters not that far, just into the pulmonary circuit. And the left ventricles are going to pump this 80 milliliters of blood further into the systemic circulation. And so we have to have more myocardium inside the left ventricle so that we can squeeze tightly and shoot that blood further. And here we have the myocardium being compared between the left ventricle, which is a lot thicker than the right ventricle. So when we contract, the pressure inside this left ventricle is going to be increased because we have a smaller space with the same amount of volume of blood as in the right ventricle. Since we have the same amount of blood within both ventricles, but a shorter amount of space, a smaller amount of space within the left ventricle, the pressure increases, and thus we can shoot this blood further into the systemic system. So it's kind of like putting your finger on a hose. The more you block this hose, the tighter the hole is for the hose, and there's still the same amount of water coming out of that hose, except there's more pressure. So now you can shoot that water further when you press your finger on that hose. We will now be talking about the arteries of the heart. Not only does the heart pump blood for the rest of the body, but it also pumps blood for itself. I mean, the heart is a muscle and it needs oxygen, and oxygen is transported via the arteries. And so out of the aortic region, out of the aorta, comes the coronary artery. So we have two subdivisions. Here we have the right coronary artery, and then we also have the left coronary artery. Now, we're going to be focusing on the left first. Now, the left is a bit special because it wraps around the heart, and it's kind of like the circumference of the heart. It goes and it wraps around. So we call this guy right here the circumflex artery of the heart. Now, the first branch that comes out of this left coronary artery is going to descend into the anterior portion of the heart. Anterior just means the front of the heart. And since it descends and it's on the left coronary artery, we call this the left descending artery. Left descending coronary artery. So it is this guy right here, and they call it a different name. Don't worry about it, just pretend it says left descending coronary artery. And the reason why we're learning about this, why should I care, is because if you have any blockages inside this left coronary artery, you're going to have a possibility of having a heart attack, so a myocardial infarction. And so when you're learning EKGs, if you're a paramedic or a medical student like I am, when you learn EKGs, you can actually see, hey, we have a heart attack occurring within the anterolateral portion of the heart. And you can see that by the leads, actually V3 and V4, and actually V3, V4, V5, and V6. When you have elevation on the ST wave, which we'll learn about later, that's going to be a myocardial infarction within the anterolateral portion of the heart. And that stems mainly from the occlusion or the blockages within the left descending artery of the heart, of the coronary artery. Now moving on, we have these little branches that branches off of these big guys right here. So these little small guys are called marginal arteries. So we have marginal arteries, and likewise we also have the marginal veins right here. So when we have it in an artery, they're just called marginal arteries. They're just small. And what they do is that they allow the uppermost portion, I would say like the uppermost portion of the ventricles, to receive oxygen. So the marginal arteries supply oxygen to the very surface of the ventricles, and the marginal veins will take in that deoxygenated blood and send it back into the heart. And notice that it all goes into this very big vein, and this is called the great cardiac vein. So that is a great cardiac vein, and then it's going to wrap around into this small little hole next to the inferior vena cava. And so the inferior vena cava will take in deoxygenated blood from the great coronary vein, and this right here is called the coronary sinus. This big tube right here is called the coronary sinus. So there is a small hole right there, small hole, and the deoxygenated blood from the heart goes into the inferior vena cava via the coronary sinus. If we look on the right portion of the heart, we have the right coronary artery. And the right coronary artery is also going to branch into these marginal arteries right here, and that supplies the right ventricle with oxygen. And again, we're going to have these little marginal veins right here, right there. So we have the left ventricle veins. Now if we go to the right portion, we're going to have the right marginal veins right there. But let's kind of go a little bit further. So right here we have more veins, and these actually have a name. So let's kind of look at it. We have the small cardiac veins, and that again just takes in the blood supplied from the arteries from the heart, and it just pulls it into the great cardiac vein. So nothing really special going on here. What is special about it and why you should learn about it is because a lot of heart attacks arise from the blockages of these arteries. And so if you know that this portion right here is the lateral portion, this right here is the septal portion, like the middle. You can kind of see the partition in the middle. Right here, right ventricle, left ventricle, that's the septal region. And this guy right here would be the anterior region of the heart. If you can see this on the EKG, you can see where this heart attack is originating from. And so that's why we're taking time out of our day to kind of look at the arteries and see that this is the name. So the main takeaway is that a lot of these heart attacks occur because there's a blockage within the left descending coronary artery. This guy right here, this guy is the circumflex artery. So again, circumflex artery. The small branching ones are marginals. This is a great cardiac vein. It goes into the cardiac sinus, which goes into the inferior vena cava. The heart is able to contract and relax by the conduction system. So using this conduction system, we can actually kind of stimulate the heart into opening and closing these valves, into releasing the blood into the circulatory system. And it's really such a beautiful process. And the way the heart does this is actually through the use of these little pacemakers. So here we have a collection of pacemakers. Here we have the sinoatrial node, and this guy right here, he's the main person stimulating the heart. So he is above the right atria. And what happens here is that this guy is able to stimulate himself electronically and to send an impulse into the other nodes of the heart. So between this node and this node right here are little internodes. This is kind of like the information highway from the sinoatrial node to the atrioventricular node, the AV node. So here we're going to have three types of internodes. Here we have the anterior internode, right there. So that is the anterior internode. We're going to have this middle internode. This is called the middle internode, right there. So it's this guy right here. And lastly, we're going to have the posterior internode. And they all send an electronic signal to this guy. So this guy right here is between the atria right here, and it's also between the ventricle. So we call this the atrioventricular node. Now the atrioventricular node will send its signal into this little internode right here. And this guy is really special because eventually he's going to branch into a lot of little nerves within the left ventricle. What you see here is also reflected in the right ventricle. It's just not shown in this model. So this little internode right here is very special. It has its own name. It's called the bundle of His, or the atrioventricular bundle. Let's see if we can actually, we can click it. So we have the atrioventricular bundle, also known as the bundle of His. And now we're going to branch out into the left ventricle bundle. So that's what you see over here. We have this left ventricle bundle. So we have a bundle branch of the atrioventricular node. If you were to have this on the right side, it would be the right atrioventricular branch bundle. Now, it eventually goes into the ventricles right here. But what if we have a blockage of signal right here? If we have a blockage of signal, then we don't have the full stimulation within the ventricles. And we would call that a bundle branch block. And those are pretty common when you're looking at EKGs. Another common abnormality would have to be a blockage within this bundle of His, and that would be called an infrahistian blockage, and they're very common. So again, to recap, we start at the sinoatrial node. It's going to send its signals, the little pacemaker signals, into the atrioventricular node right here between the atria and the ventricle. Shown here is the left ventricle of the heart. The atrioventricular node is going to send its signal into the bundle of His, the atrioventricular bundle. The bundle of His is going to send its signal into the, in this case, the left branching bundle of the left ventricle. And you're probably wondering, well, if we're so excitable, if we're sending electricity down this wire, how come it's not prematurely electrifying or stimulating the wall of the ventricle, the septum of the ventricle? Well, the reason why it's not prematurely firing is because this guy right here is insulated. It is insulated right here. You see this little tube of muscle and tissue. It is insulating the atrioventricular node. And also this white portion that you see here is called the cardiac skeleton, and it's made of collagen. And collagen is not very conductive to electricity, and so this prevents the premature firing of the electricity that is carried within these internodes into the ventricle muscle. So this cardiac skeleton is preventing the premature depolarization of these cardiac cells within the ventricles of the heart. Also, within the conductive system of the heart, when the sinoatrial node fires, it will reach the atrioventricular node, and then there's a pause within the atrioventricular node, and that allows the heart to fully fill with blood before this atrioventricular node sends its signal into the ventricles to contract. So first we're going to fill up the ventricles with blood, we're going to pause, and then we're going to send the signal for the ventricles to contract and to shoot that blood into the pulmonary trunk and also the aortic arch. And also, there's these little nerves within the ventricles near the apex, and they go from the bottom of the ventricles all the way to the top of the ventricles. And so when they receive this signal from the atrioventricular node, they start contracting the bottom of the ventricles, and there's more contractions as you go up the ventricles near the pulmonary trunk and aortic arch, and that allows the blood to fully be pushed into those arches. It's kind of like when you squeeze a tube of toothpaste. You squeeze from the bottom so you get all the blood all the way out to the top. And so again, you have more little nerves within the ventricles, and those are called Purkinje fibers. Before we move on, I have to inform you that the sinoatrial node is the guy who sets the pace of the heart. Now, the fastest pacemaker cell will determine the rate of the heart. And so the sinoatrial node is the fastest pacemaker. We call this the pace setter node, pace setter. So it's faster than the atrioventricular node. Now, if for some reason we have an abnormality in which the sinoatrial node can no longer fire, the atrioventricular node is going to pick up the slack. He's going to say, okay, well, we lost our fastest runner. I have to run now in this marathon. I have to take the lead. I have to call the shots. And so the atrioventricular node is not as quick as the sinoatrial node. Right here, we would only have about like 60 beats per minute maximum by the atrioventricular node. And, frankly, we can survive with the atrioventricular node firing by itself, but it's not as efficient as having the sinoatrial node firing. So it's something that we don't want, but we can live with it if it happens. We have to ask ourselves, how is the sinoatrial node and the atrioventricular node able to stimulate themselves and to send action potentials to the cardiac cells? Well, first we have to realize that the SA node and also the atrioventricular node, so the atrioventricular node, are actually a collection of cells called cardiac conductive cells. And what makes them special is that they have little channels in their membranes that will intake sodium. So here we have these little channels. We have these little channels right here. And these guys are open right here. Okay, these guys are open. And what they do is that they are open and they allow the sodium from the extracellular fluid to go into the membranes. And when you have this happening, you have a small buildup of sodium inside the membranes of the sinoatrial node and the atrioventricular node, which are just cardiac conductive cells. So when you have this positive building up, you push the membrane potential towards a positive value. You push it towards 0. So initially we start really negative. We start negative at negative 60 millivolts. The more positive it becomes, the closer it becomes towards 0. So the buildup of sodium pushes this negative value into a more positive value, negative 40 millivolts. At negative 40 millivolts, what happens? Well, at negative 40 millivolts, you have the opening of the calcium channels. So initially, you had this guy right here being closed, and now you have this opening. So this is at negative 60 millivolts. We have closed calcium channels, and now at negative 40, which is a lot more positive than negative 60, you have this opening in the calcium channel. And so now you have extracellular calcium flowing into this channel. So now you have a quick buildup of calcium. So that's why we are depolarizing very quickly. So this guy right here goes from negative 40 and we make it super positive. We actually go up to about 15 millivolts. And then we're going to have the exiting of potassium. So here, let's kind of make this right here. We have this guy right here. So because you have such a positive calcium right here, this is actually 2+. You have calcium 2+ right there, calcium 2+. You have a lot of these guys, and you also have these positive potassium ions. Well, it's kind of like putting two magnets together. When you put them on the same pole, positive with positive, they want to repel. And so now you have too many positives. And so potassium is going to be pushed away from the calcium, and it's slowly going to leave the cell. It's going to leave the sinoatrial node and the atrioventricular node. So now you have a rapid outflux, this outflux of potassium. And when this happens, you're losing positive energy. All the positive ions are leaving. And therefore, we're going to go from positive 15 millivolts all the way down to a negative value of negative 60 millivolts. And that's basically the action potential of the sinoatrial node and the atrioventricular node. So we have this slow buildup of sodium, and that gets us to the threshold value. The threshold value is the minimum number or minimum membrane potential we need to create a depolarization. That is negative 40 for the sinoatrial node and the atrioventricular node. When this happens, the calcium channels open and we have a rapid influx of calcium going into the cells. And that creates an action potential, electricity, like a snap. And then we're going to have the outflux, the exiting of the potassium ions, because they're being pushed away from the calcium 2+ ions. Positive with positive, like and like repel, and the potassium leave the cell. And then that allows us to repolarize. That means to go back to a negative value, and we have the cycle starting over again and again. And as you can see, it's very quickly. It's about like 0.8 seconds to even do this, and it's really fast. That's why the sinoatrial node is the pace setter of the heart. That's great that we talked about the sinoatrial node and the atrioventricular node, but that only applies to the conductive cells. What about the contractile cells? What about the cells that actually are a part of the muscle of the heart? So the rest of the cells, like a vast majority of the cells of the heart, like 99% of the heart cells are actually contractile. So we have the cardiac contractile cells. And these guys right here are like the myocardium. They squeeze together and they push the blood out. But how do they form that contraction? Well, what happens here is that we receive that electrical impulse from the atrioventricular node into the Purkinje fibers, and it goes all around the myocardial cells of the ventricles. So when those cardiac cells receive that signal, the voltage-gated sodium channels open. So before we have this closed membrane, and now we're going to have this open membrane. So here we have something like negative 90 millivolts. These guys are closed, but when we hit something like negative 80 millivolts, well, guess what? We're going to open. And when this happens, the sodium is going to enter the cardiac contractile cells. So now we have sodium entering this cell. So we have sodium right here. And now you have a buildup of positivity. So this positivity is building up. When you have this positivity building up, you now have the calcium channels opening. But hey, notice that it says slow calcium channels opening. Why is it slow? Well, it has to be slow because you have to have enough time for the heart to expand and contract. So if you had fast calcium channels opening, you would have a very fast contraction, and you wouldn't have enough time for these ventricles to fill up with blood and to contract fully. So if we had something that was quick, well, guess what? It's going to be like this. Something that is a lot quicker. And that this area right here is where most of the ventricles get their blood and they contract fully. So we need to have these little slow calcium channels opening. So a slow calcium channel kind of looks like this, and then slowly it kind of opens a little bit more, like that. So now right here only one calcium can enter, maybe two calciums can enter, and now maybe four calciums can enter here. So slowly we increase the amount of calcium that can depolarize this cell. And this is called the plateau. So most of the contraction, ooh, wow, that was terrible. Most contraction occurs here. At the plateau. So now at this point, at a like negative, let's say at 0 millivolts, these little calcium channels, they will start to close, and they close very slowly. Because you have so much calcium inside the cell, they're repelling the potassium ions inside the cell. So likewise, we have these little potassium ions that don't like calcium, and they say, ew, why are these little calcium ions here? We were here first. You know what? Let's get out of here. So they all leave. So they all leave the cell. And this is called the repolarization. Since you're losing positive ions from the cell, you slowly go from a positive number all the way down to a negative number. Let's say negative 90 millivolts. And that resets the cardiac cells. It allows them to rest. And then they set up again for another influx of sodium and an influx of calcium subsequently, and then more outflux of potassium. So to recap, sodium comes in, it increases the value from negative 90 to positive 30. When it hits positive 30, the slow calcium channels open, and slowly calcium enters the cell. We want those slow calcium channels to be slow because most of the contraction occurs with the slow acceptance of calcium. So the more calcium you have, the more contraction you have. You want that contraction to happen slowly. It takes like less than a second, but it's considered slow. You want that contraction to happen slowly so that you have enough blood inside the ventricles and you push as much blood as you can into the pulmonary trunk or the aortic arch. And slowly, these calcium channels close and these potassium ions are going to leave the cell and repolarize. Here, again, we're going to have the refractory period. The refractory period means that there is no contraction occurring, but instead we're filling up with blood. If you're like me, you're probably wondering, well, if we have an influx of calcium ions, wouldn't there be too much calcium ions inside the cell? And wouldn't that cause too much contraction? And you know what? You're right. So the body is pretty smart. It's going to have these little pumps that will pump out. It's going to pump out calcium. So we have these little pumps right here, and the calcium ions are going to go outside, and they are pumped out into the extracellular space. And now you have extracellular calcium ions. Where do they go? Well, they go into the sarcoplasmic reticulum. Sarcoplasmic reticulum. So these guys right here, they go into the sarcoplasmic reticulum, and this acts like a hotel for the calcium ions. And now we have a fully reset cardiac contractile cell. However, consider this. Since now the calcium ions have gone away, well, the potassium ions are like, hey, we can go home now. Our home is free. We can go back into our little cardiac cells. And when that happens, guess what? They restore the cell into the normal range. So you will always have a little bit of potassium going back into the cardiac cells because, hey, if 10 potassium ions were initially inside the cardiac cell and then they were kicked out by the calcium ions, well, once the calcium ions leave, the potassium ions are going to go back into the cell. So you're still going to have the little 10 potassium ions going back into the cardiac cell. So there is always a specific level of potassium ions that is naturally found within the cardiac cell. However, let's say that we are talking about the death penalty. I know it got pretty grim. The death penalty for inmates on death row, sometimes they subdue the inmate by injecting a lethal concoction that has anesthesia and tranquilizers for the inmate, and it also has a lethal dose of 100 milliequivalents, actually greater than 100 milliequivalents of potassium. Why are we injecting potassium into a person? How does that kill a person? Well, it kills a person because you're increasing the amount of extracellular space. So we're going to call this EXC, the extracellular concentration of potassium. Why is that an issue? Well, if you have more potassium outside, right here, they say this. They say, hey, hold up. Why don't we just go back inside the cardiac cells? If we all go back inside the cardiac cells, we now have a higher concentration of potassium. Why is that a problem? Well, this is hyperkalemia. And instead of going to -90, because there is a set level of potassium ions inside the cell, since we have more potassium ions, this -90 goes from -90 to a higher positive number. Let's say it goes to -40 millivolts. So now this is our resting potential. Why is that a problem? Well, it's a problem because when we have a contraction, the sodium channels are activated, but then they become inactivated by this inactivation particle. So here we have an opened sodium channel. So normally at negative, let's say 90 millivolts, normally this sodium channel is open, and so sodium goes in and it builds up its little electrical potential all the way to positive 30. But then it resets. It's going to be inactivated by this little inactivation particle. Well, how do we activate this channel again? Well, to reactivate it, we have to go from positive 30 all the way down to a negative number that is less than -70 millivolts. Notice that -90 millivolts is less than -70. However, when you have a lethal injection of potassium, you never reach this value again. You're actually more positive than -70. You're a -40. So you never reach -70. You have to be below -70 for this activation particle to become active. This inactivation particle is never going to be active again because we're never reaching -70. Instead, we're going to stay at -40. So we have to be more negative than -70 for this inactivation particle to activate. So what does that mean for us? Well, it means that you lose more and more sodium channels. If you eventually lose all the sodium channels, you no longer have the ability to contract. You no longer have the ability to have this rapid depolarization because that is based off of sodium. So with every contraction of the heart in a hyperkalemic environment, you lose more and more of these sodium channels. And eventually, you have no more sodium channels and you have no more contractions. And that person unfortunately dies of a heart attack when they are giving a lethal injection of 100 milliequivalents. So sometimes when you're dealing with a hypokalemic person, you would give them 10 to maybe 20 milliequivalents of potassium per hour. And that's under strict monitorization. So when they do that in the hospital for hypokalemic patients, you have to really document what you're doing, because if you keep pushing it for too long, maybe 5 hours, well, you're going to be hyperkalemic, and that could lead to very serious cardiac consequences. And so we can say that potassium ions will eventually increase the heart rate, because the heart is trying to get enough oxygen. It's not able to do it. It increases the heart rate, it increases the blood pressure, and eventually the heart stops beating when it becomes hyperkalemic. If you have hypokalemia, which is a decrease in concentration of potassium ions, well, this repolarization section takes a bit longer to occur. And so instead of having a normal heart rate, you're going to have a slow heart rate. And so that's when you see bradycardia, which is when the heart slows down. And that can also be very bad. So you need to have a set range for potassium. And that's why we care so much about potassium. And sodium, you could have hypernatremia, which is excess sodium, and you can also have hyponatremia, which is a decrease in sodium. But clinically, potassium is where a lot of unfortunate events happen for people. And people who are most prone to hyperkalemia, or just potassium in general, are your dialysis patients. So people with renal disease that need dialysis, they have a very sensitive range for potassium. So be on the lookout for the potassium levels of people who have end-stage renal disease. So far, we've been talking about the basic anatomy of the heart and the conduction system of the heart, but we still have to talk about the cardiac cycle, how this occurs. And really, it's beautiful. So let's get into it. When we talk about the cardiac cycle, we talk about the pattern in which the atria inflate and contract. We talk about the ways the ventricles inflate and contract. Instead, we don't use inflation and contraction. Instead, we use systole and diastole. Systole is the contraction portion of the tissue, while diastole is the expansion of the tissue. So why do we want that? Well, when we expand, we're going to be what? We're going to be increasing the amount of volume inside the tissue, inside this portion. When you increase the amount of volume, you're decreasing the amount of pressure. And so you have a high pressure system of the superior vena cava and the inferior vena cava, and also the coronary sinus. That has a high pressure to it. So high pressure goes into low pressure. When you expand the volume of the atria and the ventricles, you're decreasing the pressure inside that hollow tissue, and therefore the blood will rush into it. When the atria expand, this is called the diastole section, the diastole phase. So here in the beginning, we have the P wave, the QRS complex, and the T wave. The P wave is when the atria contract. But prior to this, we have the atrial diastole. So systole and diastole, we have the atrial diastole. So that's when the atria slowly expand, they accept blood, and then we hit this hump, this P hump. When this happens halfway, the atria start to contract, and they start to increase the amount of pressure by decreasing the amount of volume inside the atria. So they start to contract. So it's that initial contraction right there. Okay. And as you can see here on this nice EKG diagram, the systole of the atria always persists about halfway through the QR complex. So what is the QRS complex anyways? Well, the QRS complex is when the ventricles start to contract. So halfway about Q to R, the ventricles are relaxed, so they're filling up with blood. Why is that? Well, when the atria are in systole, they push the blood into the ventricles. You don't want the ventricles to be contracted. No, you want them to be in diastole, so that they can expand readily and accept that blood from the atria. So that's why the ventricular diastole only turns into systole halfway between the R and the S. It's not QRS ventricular systole. No. Halfway between the QR, you have the relaxation of the ventricular system. And the reason why we do that is because we want to accept this blood that is being pushed into the atria, into the ventricles by the atria. Excuse me. So now, since you had the atrial systole, we have to rest. So the atrial systole goes into the resting phase, the atrial diastole. So that's like a vast majority of this timeline. So like only 10% of this timeline, you actually have the contraction of the atria. So now let's focus on the ventricles. After we received the blood from the atria, well, now between the R and the S and the rest of the timeline, we're going to start this contraction. So this is what you see. You have the relaxation, that means the ventricles are accepting this blood. And then we go from this big balloon to a small balloon. So that's going to be the RS all the way past the T wave. So when it shrinks down, that means it's in what? It's going to be in systole. And when it balloons up, that means that the ventricles are in diastole. Okay, that's cool. So if we look here on the RS complex, we just accepted all this blood and now we're pushing it out. We're going to push it into the pulmonary trunk. We're going to push it into the aortic, into the aortic portion of the heart. But notice we have this little T wave, and this T wave is kind of weird. What does the T wave do? Well, the T wave is when the ventricles actually convert from a contraction force to an expanding formation. So we convert from the systole to the diastole. So instead of shrinking down and increasing pressure, we're going to swell up and start receiving more blood. So it's kind of like the reset right there. We're resetting this section. If you want it in scientific terms, the P wave is when the atria depolarize, they contract. And then between the QRS complex, the atria are going to repolarize, they're going to reset. So they take a long time to repolarize. They go from the QRS complex all the way down to the next P wave. So that's called the repolarization. The QRS is when the ventricles begin to what? They begin to depolarize and contract. And then after the T wave, that's when we see the repolarization of the ventricles. So the T wave is actually the repolarization of the ventricles. I want to bring something to your attention, and that's something called the isovolumetric contraction. And that occurs right as we transition from the Q to the S. So right at R, if we draw an imaginary line, we have the very early beginning of the ventricular systole phase. And what happens is that the ventricular pressure increases. However, all the valves, all the atrioventricular valves and the semilunar valves, they're all closed. And so you have this buildup of pressure inside the ventricles, but no blood movement. And so the volume stays the same. It is iso, it is the same. However, it is still a part of the early contraction, and that is what we call the isovolumetric contraction. It is occurring right when the R goes into the S. So if you draw an imaginary line right there, it's the very beginning of the ventricular systole phase. So all the valves are closed. Atrioventricular valve is closed. Tricuspid valve is closed. The mitral valve is closed, also known as the bicuspid. The pulmonary semilunar valve is closed. The aortic semilunar valves are closed. However, we're still contracting. There's no blood movement, no blood flow from the ventricles, but we're still contracting. So isovolumetric contraction. And likewise, when we're in the early portion of the ventricular diastole, which is kind of like 3/4 of the way past the T wave, you have something called the isovolumetric relaxation. Now, what happens here is that the pressure inside the ventricles will decrease. It takes pressure in the first place to push the semilunar valves open and to push blood into the pulmonary arch or into the aortic arch. And when we decrease the pressure inside the ventricles during the relaxation phase, the semilunar valves close because the ventricles are not as pressurized. So because we decrease the amount of pressure in the ventricles, we can no longer push the semilunar valves open because, again, we're in the relaxation phase, the diastole. Well, the atrioventricular valves are always going to be closed when the ventricles are contracting, but they remain closed when the ventricles are relaxing in the early portions. So what I'm saying here is that in the early portion of the ventricular diastole, the semilunar valves are closed and the atrioventricular valves are also closed. However, we have this relaxation of the ventricles. When the ventricles relax, the pressure inside the ventricular area decreases and we no longer have enough pressure to open these semilunar valves. So therefore, we're relaxing, we have no blood flow. That is called isovolumetric relaxation. When we take blood pressure, we get two numbers. We get the top number, which is the systolic number, and then we get the diastolic number, which is the bottom number. And when we get those numbers, we're measuring the systole pressure of the ventricles, and we're also measuring the diastole number, or the diastole pressure of the ventricles. So the maximum pressure on the systolic portion of the ventricle, so after we finish contracting, let's say that we get a number 180 over 120. That's really bad. You have really bad hypertension. The blood pressure is really high. Why is that? Well, if we have a maximum pressure exerted of 180 millimeters of mercury by the ventricles, that must mean that the ventricles are contracting very heavily. So we have an increase in contractual force. That means we have an increase in the force that is pushing that blood out into the semilunar valves, which increases the pressure of the blood. So that blood pressure is going to be really high, 180. So when we see a number of 180, that must mean that the ventricles are contracting very, very hard. If we have a number for the diastolic phase, so if we have a 120 for the diastolic number, that means that when the ventricles are fully relaxed, we have some pressure inside the ventricles. And that's a lot of pressure for a relaxation phase. That's not normal. Typically, you want 120 over 80. You can have 110 to 120. You can have 60 to 80. That's a healthy range. 120 over 80 is kind of like the standard. But if you have something that is markedly elevated, like 120 for the diastolic, that means that at rest, the ventricles have an abnormal amount of pressure being pushed onto it. So we need to see a doctor because there's something going on with the heart. It's contracting too much, and then it's not fully relaxing. It's always strained and it's always under stress. You don't want a high blood pressure because that has negative consequences on your heart. So blood pressure is actually a diagnostic tool for the heart. And to recap, high systolic pressure means that the heart is contracting too hard. High diastolic number means that when the ventricles are at rest, there is a lot of pressure on the ventricle walls and it's not fully relaxing as it should be. And if you have a low blood pressure, like let's say 90 over 40, that must mean that the ventricles are not contracting as hard on the systolic phase. And if you have a 40 millimeters of mercury for the resting phase, that must mean that we're relaxing too much and we have a weakened heart. So that's why we would have a low blood pressure, because that heart is so weak that it can't push that blood into the systemic circulation as efficiently. So that must mean we have a low blood pressure. And now we're going to look at the cardiac cycle in detail. So again, here we have this nice little scroll. So first, we're going to have ventricular diastole. So that's when the ventricles are going to swell up. And when they swell up, they're going to accept very passively blood from the atria. So the atria is not contracting. And yet we still have transfer of blood from the atria into the ventricles. So right here, we have both the atria in diastole and the ventricles in diastole. So they both swell up. And when they swell up, you can see on the tricuspid valve right there that the blood that is accumulating within the atria is passively entering this small hole in the tricuspid and is going to be filling up this ventricle. And in fact, 80% of the blood in the ventricle is passively being passed within the atria to the ventricle. So there is no contraction yet. However, 80% of the blood will be passed into the ventricle passively. And now you're going to have this P wave. We're going to have the atrial systole. So that's when the atria contract. And when they contract, we have more opening of the tricuspid valve. Similarly, we also have this occurring at the same time as the bicuspid valve. But right now I'm just showing you the right ventricle and the right atria. But it's also happening on the left side. So when this happens, the ventricle or the atrial will enter diastole, so they're going to relax. Here we have the ventricle diastole. So the remaining 30% of blood is squeezed out from the atria and is pushed into the ventricles. And now the ventricles are accepting all that blood and they're going to swell up right here. So right now the atria are repolarizing. They're in the diastole. And now we're going to hit that R wave, the peak. And you're going to see right here that the ventricles are going to contract. So now we're entering ventricular systole. Ventricular systole. So now they squeeze all that. They squeeze right there. Boom. Okay. And now the ventricles have finished their systolic phase. And now we're going to enter the diastolic phase. That means that we're all going to expand. So you can see that the atria is expanding. And the ventricles are also expanding right there. Expand. Okay, expand and then contract. So we can see that in real time. So we just finished talking about the atria and the ventricles contracting and relaxing. But let's talk about the valves. Let's talk about the atrioventricular valves and also the semilunar valves. So here we have kind of like the brief opening of the atrioventricular valves, and that allows the blood to passively flow into the ventricles. About 80% of the blood will flow passively, and that is going to persist up until this point right here, up until the contraction of the ventricles. The reason why we close when we start contracting the ventricles is because if the ventricles contract right now, they're going to push blood back into the atria, and that's really bad. So we're going to close right there. Okay. We're going to close right there. And at this point right here, let me see if I can get it. This point is closed. This guy right here is also closed. And also, these semilunar valves are closed. And yet, we are increasing the pressure inside the ventricles. So we're increasing the pressure inside the ventricles, but we're not increasing the amount of blood inside the ventricles. The amount of blood inside the ventricles stays the same, but the pressure increases. That is called isovolumetric contraction. And really, it kind of occurs past the R point. So now we slowly contract, well, we quickly contract the ventricles, and when that happens, we open the semilunar valves. So that allows the blood to flow past the semilunar valves right there. Okay, so that happens, and then the semilunar valves are going to close once again, and notice that the atrioventricular valves are closed and the semilunar valves are also closed, and yet we are relaxing. We are relaxing. So here we have it again, we're relaxing. It is very brief for like a few milliseconds. We're relaxing, we're increasing the space in the ventricles, but we're not increasing the amount of blood going into the ventricles. So that is called isovolumetric relaxation. It occurs when the ventricles are expanding, but the valves are closed. When we auscultate somebody, we put a stethoscope on their chest and we listen to their heart. And we hear some sounds. We hear doop, 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 doop. What is that sound? Well, the first doop is when the atrioventricular nodes close. So here we have, focus on this guy right there. He's going to close and it goes doop. The second sound is when the semilunar valves close. It's going to make the duh sound. So doop doop. And then we go duh. So first one to close is the atrioventricular node. Doop. And then we have the semilunar valves closing right here. Doop. And that is the second sound. That is denoted by S2. So the first sound, S1, is when the atrioventricular node valves close, and the semilunar valves closing is going to be the second sound. And now we're going to listen to a sample of normal heart sounds. Remember in the beginning of the video in which I told you about the possibility of having a mitral valve prolapse, in which some of the blood is being pushed from the ventricle as it contracts back into the atria, the left atria. And that is because there is a failure of the chordae tendineae. So it is not fully closing this valve, and some of the blood is rushing back into the atria. And now this is how a mitral valve prolapse sounds like. And it's very common within women and young teenagers. Here we have the best auscultation areas for the heart. So if you want to listen to the mitral valve, if you suspect that there's a mitral valve prolapse, you want to listen to this area. It's right next to the pectoral line on the left portion of the body. And I would recommend using the bell of the stethoscope, so like the smaller head, to hear that low sound of the mitral valve prolapse. If you go a little bit further up near the middle of the chest, you can hear the tricuspid valve. And then further up, you can hear the semilunar valves. So here would be the aortic semilunar valve, and here would be the pulmonary semilunar valve. So those are the best areas for auscultation. We will now be talking about the physiology of the heart. So here we have kind of like the end. We have the end of the atrial diastole. So the atrial diastole is now finished, and we're on the cusp of doing the ventricle systole. So when this happens, the ventricles are fully filled with blood. So each ventricle, so if we have this little egg, we have this portion right here, actually like this left ventricle is going to be holding about 70 milliliters of blood, and this other ventricle, the right ventricle, is also going to be holding 70 milliliters of blood. And that is the preload. That is the preload volume. So that is the amount of blood that we are preloading into the ventricles before we shoot it into the other vascular systems, like the systemic circulatory system or the pulmonary circulatory system. That is the preload. Another way that you can call this is the end diastolic, diastole volume. So typically this volume would be about 130 milliliters for an average person, and that again is the amount of blood that is pumped from the atria into the ventricles. The ventricles have not yet pushed 130 milliliters of blood into the circulatory systems. So you can have a range from 130 milliliters, you can even have 140 milliliters, like we have in this case. 70 and 70 makes 140, and that's the end diastole volume. Each individual ventricle, when they push 70 milliliters into the pulmonary trunk or the aortic area, that individual ventricle is pushing 70 milliliters of blood, and this is called the stroke volume, and that is SV. So the stroke volume is how much blood one ventricle by itself can push, and typically they are the same value. So 70 plus 70 is 140. If you had 65 and 65, that'd be 130 milliliters. However, whenever you have this pumping of the ventricles, you don't pump the entire amount of 70 milliliters of blood. You will always have a residual amount of blood in the ventricles. It's kind of like when you're drinking something with a straw. So let's say you're drinking some soda and you're drinking with the straw. So as hard as you try to get that last bit of soda, you're always going to have that little bit of soda at the bottom of the cup. No matter how hard you try with the straw, you're always going to have a little bit of soda at the bottom of this cup. And so when the ventricles pump the blood, they don't pump the full amount of 70 milliliters. Instead, there's still some blood at the base of the ventricles. And this is called the end systole volume, or the ESV. And now we have something called the cardiac output. So we have the cardiac output, and really that's the stroke volume, how much blood you pump in one heartbeat, multiplied by the heart rate. In the real world, we aren't typically given the stroke volume, and we have to calculate it ourselves. And so stroke volume is really just this. It's simple. Stroke volume is equal to the end diastole volume minus the end systole volume. So how much did you start with minus how much did you have left? So let's say that we started with 140 milliliters and we ended up with only having 20 milliliters inside the heart left over. So that must mean that the stroke volume is going to be what? Is going to be 120. Now 120 milliliters divided by two ventricles is going to be 60 milliliters of blood per ventricle, per vent. And that's the stroke volume. So let's say that we take 60 milliliters right there and we multiply that by 100 heartbeats per minute. So we have beats per min right there, and this is again in milliliters. So that's going to be what? 6, and that's 3 zeros. So like that. And again, that is what? That is milliliters per minute. Well, 6,000 milliliters, that's actually just 6 liters of blood pumped per minute by the heart. So with a stroke volume of 60 milliliters and 100 beats per minute, the heart outputs 6 liters of blood into the body. So if you're just briefly jogging, the heart has to pump 6 liters of blood in 1 minute to supply your body with adequate levels of blood. And your cardio output is always going to vary, whether you're stressed or you're sad or you're happy, or if you're running from a bear, if you're scared, if you're eating eggs in a box with a fox or in a house with a mouse. Whatever happens, it's so subjective to your external stimuli and your internal stimuli. So the cardio output varies. If you're sitting down, you may be only doing 3 liters per minute. If you're running a marathon, you may be doing 8 liters a minute. It always varies depending on the stimuli or age or sex of the person. And stroke volume can also be used when we're doing echocardiograms. So an echocardiogram will use the stroke volume to determine how much blood is pumped out of the heart per beat. So that gives the ejection fraction. And that is always a percentage. So when you see a report from the cardiologist and it says this person's ejection fraction from the echocardiogram is only 30%, that means per beat of the heart, per contraction, there's only 30% of blood being pumped out of the heart. So the heart is weak. Typically, we want a value that is above 55%, and that, my friend, is something that is good. If we look at this relationship between the stroke volume and the heart rate, we can see that if we increase the heart rate, we also increase the cardiac output. And there are several ways in which the body will decrease or increase the heart rate, and those are actually the cardiac control centers of the brain via the nerves. So the body has multiple ways in which we can increase the heart rate and in ways that we can decrease the heart rate. The way that the body dictates this, one of the ways at least, is through the use of the medulla oblongata. So that is an O oblongata. And the medulla oblongata uses two centers. It uses the cardio accelerators, and also uses the cardio inhibitors. So a good example of the vagus nerve would have to be one of the cardio inhibitors. So the vagus nerve is also a cranial nerve. So this is a cranial nerve, and specifically it is the 10th one, or the Roman X. So what this does is that it's going to send a signal to the sinoatrial node and also the atrioventricular node, and also part of the atria and part of the right ventricle, or I guess the ventricles itself. Anyways, so it's going to increase the amount of acetylcholine, And the reason why that's important is because acetylcholine is going to open the potassium ion gates. So when we increase the amount of potassium ion gates, we have a release of potassium from the heart. So when sodium tries to go inside the cell, let's have the cell right here. When sodium tries to go inside here, they are going to be repelled by potassium. Because again, plus and plus, like and like, they will repel like magnets, sticking away from each other. So now sodium will still enter the cell, but very slowly. So now we have a longer depolarization effect. So it takes us longer to depolarize. Say it takes longer to depolarize. An example of the cardioaccelerator would have to be the sympathetic cardial nerve. So that originates within the T1, if you want to be a brainiac, through T3 of the thoracic spine. And what it does is that it's going to connect to the atria and also to the ventricles, the ventricle muscles. And what it does is that it's going to release epinephrine, and it's also going to release norepinephrine. So epinephrine is adrenaline and norepinephrine is noradrenaline. So these are catecholamines released by the adrenal medulla. And what this does is that they are both going to increase the heart rate. It's going to increase the heart rate. It's also going to increase the blood pressure. Why is that? Well, epinephrine is both of them really are going to bind to something called beta receptors. So there is a beta receptor right there. So we have beta 1 receptors. We also have beta 2 receptors. Epinephrine will bind to both of them. However, epinephrine, adrenaline, is going to love binding to the beta 2 receptors. Norepinephrine is also going to bind to the beta receptors. However, norepinephrine, for the most part, like 99.999% of the time, is going to bind to the beta 1 receptors. Epinephrine, most of the time, is going to bind to beta 2 receptors. Sometimes, once in a while, it can do beta 1. Not always. But norepinephrine is almost always going to bind to the beta 1 receptors. And so if we can block the beta receptors, we can decrease the heart rate, we can decrease the blood pressure, and that would be beneficial for patients who have high blood pressure. And so we can prescribe drugs that are actually beta blockers. And a good example of this would have to be metoprolol, succinate, succinate. And also another flavor of this is metoprolol tartrate. So this is a typical beta blocker, and it's going to decrease the heart rate and also decrease the blood pressure. However, you have to be careful, because when you give this medication, it will decrease the heart rate. And so you never give to a heart rate under 60. Under 60 is really bad, okay? So just be careful when you're working with metoprolol succinate or metoprolol tartrate, because, well, you run the risk of having bradycardia. We will now be talking about the cardiac reflexes. So the cardiac reflexes is the way that the brain senses the stimuli in the body. So maybe we have low oxygen, or maybe we have too much hydrogen, or maybe we have too much potassium, we got to do something. It's the way the body senses those stimuli and acts accordingly. So we have different receptors in the brain that do different things. For instance, we have proprior receptors. And these guys right here, they sense that the muscles are working. So muscles are doing stuff, or exercising, right? Exercising. So let's say you're lifting weights. Well, the body is going to say, hey, I'm lifting weights, send that to the brain. The brain says, oh, you're lifting weights? Well, I guess you need more blood pressure, you need more oxygen to the muscles, so we're going to pump harder, and subsequently we're going to increase the heart rate and increase the blood pressure so that the muscles get fed blood for oxygen. So that's a proprioceptor. It's just kind of like muscle activity. We also have the chemoreceptors. The chemoreceptors sense chemicals, so they sense if the calcium level is too high, or if the oxygen concentration is too low, or the concentration for sodium, and the body sends those signals to the brain, and the brain acts accordingly. We also have the baroreceptors. So these receptors sense the amount of pressure. So let's say that we have too much pressure in the atrial walls stretch, and they say, hey, there's too much pressure on me, let's slow down. And it sends the signal to the brain. The brain says, okay, we're going to slow down the heart, and the heart rate slows down. So it uses the baroreceptors to sense pressure. So senses pressure. And finally, we have the limbic system. So the limbic system is kind of like the upper function of the brain. So it's like, oh, the emotions, how you feel about something. For instance, if you're panicking, well, guess what? The brain is going to send signals to the heart, and the heart's going to pump even faster. If you're angry, the heart rate is going to go sky high. If you're happy, the heart rate also elevates. And so this limbic system, we can say it's the emotional is going to increase the heart rate, or it has a direct correlation to the cardiac response. For instance, when a person's having a panic attack and you put an EKG on that person, it looks like they're having a heart attack. In reality, they're not having a heart attack. It's just that the limbic system is going haywire and is affecting the heart rate and the blood pressure. Let's talk about the baroreceptor reflex. So the baroreceptor, again, is going to sense the amount of pressure in a vessel. So let's say that for the vena cava, if we increase the amount of pressure right here, so normally the vena cava is like this, and we increase the pressure so that the vena cava widen, well, the baroreceptors, the baroreceptors on the lining of the vessels are going to start firing. So we have the baroreceptor increases the rate of fire, so they start sending out more signals, and when this happens, the brain decreases the amount of blood pressure, and the way it does that is that it's going to decrease the sympathetic response. What does that mean? That means that when we increase the amount of firing, the amount of signals produced by the baroreceptors, we decrease the amount of norepinephrine. And we also decrease the amount of epinephrine. And that means that we decrease the heart rate and we decrease the blood pressure. And now we have this vena cava, instead of being wide and swollen because of the increased pressure, it will now decrease in pressure. And again, that is the baroreflex. So that is the baroreceptor reflex. We have another similar reflex within the atria. So here in the atria, we have special baroreceptors, and these baroreceptors are called the atrial baroreceptors. And this reflex that we're about to describe is called the atrial reflex. So these are not just normal baroreceptors. Instead, they do something different. So let's say you're exercising, and when you're exercising, you have more blood being returned into the heart. So we have more blood coming into the vena cava. And so all this blood rushes and it pools into this atria. And when that happens, the pressure in the atria increases and the walls of the atria expand to make room for this new blood. when this expansion happens, the baroreceptors sense it and they start firing their signals. So now the signals from the baroreceptor increases. So we have the baroreceptors increasing the signals. And instead of decreasing the heart rate, instead we increase the heart rate. Because it says, oh, hold up, the heart needs to get more blood flowing into the body because maybe we're exercising or maybe we're running. What I know is that the body is returning all this blood. That must mean that we have to speed up the heart rate so that we can get all this blood back into the body because the body needs it. It needs the blood for the oxygen. And so it's going to increase the heart rate so that it can subsequently send all that returned blood back into the body. And this is called the atrial reflex. Another name for this would have to be the Bain bridge reflex. For the chemoreceptors, that's going to be a little different in the process. So here, the chemoreceptors are actually being controlled by the vagus nerve, vagus nerve, and also the glossopharyngeal nerve. So if we have the glossopharyngeal, pharyngeal nerve. So the vagus nerve is actually the 10th nerve, cranial nerve, and the glossopharyngeal nerve is the 9th, the 9th nerve, cranial nerve. And these guys are kind of like the main boss for these chemoreceptors. So they're always going to be sensing the concentration of certain ions and certain gases in the blood. A good example of this would have to be the oxygen concentration becoming too low. So if the oxygen concentration is depressed, well, the heart rate is going to increase and the blood pressure is going to increase as compensation for the decrease in oxygen. So really the heart is saying, hey, I have to reduce the amount of acetylcholine and I have to increase the amount of epinephrine in the heart because this blood that I'm pumping doesn't have a lot of oxygen. So instead of just pumping the normal amount of blood that has a little bit of oxygen, let's pump this blood faster so that the amount of oxygen that I do have can be sent to the circulatory system. So a little bit, even if it's a little bit, if we pump just enough, we might compensate for the decrease of oxygen concentration. So we can have more blood pumping into the systolic or into the systemic circulation, even if the blood pressure is depressed. We try to compensate for the lack of oxygen concentration within this blood by overflowing the body with this low concentrated oxygen blood. So here's an example of this. Normally we have this much blood right here. Only this much oxygen is in that right here. So now, as compensation, we're going to increase the amount of blood we have. And now we have this much oxygen. Normally we just pump this much blood and we have this much oxygen. So as you can see, as compensation, normally, well, in this example, we started off with a low oxygen concentration. So now, as compensation, we have to increase the amount of blood we pump so that the amount of oxygen in that blood is kind of normal to what we would normally pump. So recall that when we're dealing with epinephrine and norepinephrine, the epinephrine and norepinephrine are going to bind to the beta 1 and the beta 2 receptors, and that's going to increase the heart rate and also increase the blood pressure. Why is that? Well, the beta 1 receptors and the beta 2 receptors are going to open, the sodium ion gates. And so you have more sodium, you're going to have a quicker depolarization. So that's going to increase depolarization rate. And that increases the heart rate and subsequently increases the blood pressure. In addition to this, You have to remember that beta 1 receptors and beta 2 receptors not only open the sodium ion channels, but they also open the calcium ion channels. So now we have more muscle contraction. So this is going to cause cardiac contraction. And if you want to be a smarty pants, adrenaline and norepinephrine are going to increase. So we have epi and norepi. They're going to increase the amount of protein kinase, which will open the calcium ion channels. So that's how the epinephrine and norepinephrine increase the heart rate and the blood pressure. But what if we want to decrease the blood pressure but not the heart rate? What do we do for that? Because metoprolol tartrate will decrease the blood pressure and decrease the heart rate, but we don't want to decrease the heart rate. What if we're at 60 beats per minute? Well, we have another option. We can decrease the calcium channel openings, so we can block them. We can use something called the calcium channel blockers. And so if I block this calcium channel, I can decrease the blood pressure without affecting the heart rate. I can just decrease the force of the heart, because not enough calcium channels are opened, not enough calcium can enter the heart and cause a strong contraction, and that would decrease the blood pressure. So what are the drugs that we use? We can use a drug called Atalat XL, another one called Norvasc, and another one called Cardizem. And the brand names are here, and now we have the generics, and that's called Nifedipine XL. We have amlodipine, bisalate, and then we have diltiazem. So here we have the generics, and these are kind of like the main trio for the calcium channel blockers. That's going to decrease your blood pressure without affecting the heart rate for the most part. However, the exception is that Cardizem can also decrease the heart rate because it acts partly on the sinoatrial node. We will now very, very briefly touch on EKGs and how they're read and the orientation of the EKG. And notice that this is really a specialty. This is what cardiologists do. They look at EKGs and they can say, oh, you're having hypothermia, look at this Osborne wave. And frankly, it's really in depth, so don't expect too much. Okay, so when we do a 12 lead, it's when we stick about 6 different stickers on the chest, and each sticker correlates to a different position on the heart. So we have leads V through 6. So we have V1 all the way up until V6. So V1, V2, and we're going to have V3, V4, and finally V5, V6. I pair them differently because depending on where they're placed on the body, you can see different areas of the heart. So V1 and V2 are going to be on the septum. They are going to show the walls. These guys right here are the walls of the ventricles. So we have the walls of the ventricles. We have the septum of the ventricles. That's this region right here. This guy right here, the 3 and the 4, that's going to be the anterior portion. That's the anterior portion. So that's going to be like right here in that section. That's V3, V4. Now, V5, V6, that's going to be the lateral portion of heart. So that's this part right here. So that's just the ventricle leads. What about the actual leads? So lead 1, lead 2, lead 3. So you can't really see it, but it says 1 right here. the leads actually show you a different angle of the heart. So for instance, we can say that here we have the eye, and the eye is looking at the heart at an angle of what? At an angle of 120 degrees. For the first lead, we're looking dead straight at the heart. So we're looking at a 0-degree angle at lead 1. At lead 2, we're looking at the heart right here. So let's draw the eye. The eye is right there. We have this little pupil, and we're looking at the heart at an angle of 60 degrees. And you're probably wondering, well, what does AVR mean? What does AVF and AVL? Well, that means augmented vector right. So that is the augmented view of the right heart. We have the AVL, which is the augmented view of the left portion of the heart. And then we have the AVF, which is the augmented view of the bottom of the heart, called the foot. So this is an augmented vector foot. A nice way to think about it is that lead 3 plus lead 2 add up to give you the augmented vector foot. So when you're looking at lead 2 and lead 3, you want to kind of glance at AVF, and that is going to kind of give you like a combination of both leads into one picture, and the AVF is very important. However, we don't really use AVR. You can use AVR in the EKG, but we just kind of glance over it. We call that Mr. Lonely, because whenever you read an EKG, you kind of just ignore it. All right, so let's actually look at a healthy EKG. Here we have a very healthy looking heart, and the way that I look at the EKG is as follows. I'm going to use the acronym I see all leads, and we also have the high lateral. That's not a part of the acronym, but the acronym is going to go the inferior of the heart, so this is going to be the bottom of the heart. This is going to be lead 2 and lead 3, and also the AVF. So we have the AVF. Then we go to the septal portion of the heart. That's going to be leads that actually V1 and V2. Then we go to the anterior of the heart. So all is going to be anterior. That is V3 and V4. V4. Then we go to the lateral portion of the heart. So that is near the armpit or the axillary of the person on the left side. That is going to be V5 and V6. The high lateral portion is looking at the heart like this right here. So this is the lateral portion right here. The high lateral is going to be this section. So it's even higher next to the semilunar valves. And the high lateral is seen right here. So it's a combination of lead 1, and also the AVL, so that the augmented vector left, so the AVL. So we had lead 1 and also this section. So this is what we're looking at. So you can kind of get a picture of what we're looking at when we see I see all leads and the high lateral portion of the heart. So a nice pro tip is that if we look at lead 2 is always going to give you the best picture of a P wave. So lead 2 is equal to P wave. You're always going to have the best picture of a P wave on lead 2. If you don't have a good picture on lead 2 of a P wave, you may have a heart condition. So be on the lookout for your P waves. And anyways, if we clear this board, we can see that everything looks pretty nice. For instance, if you can see this P wave right here, this P wave, it goes down and it's going to go up in the QRS complex, and then it's going to go very nicely down, and we have the ST wave. So that's when the ventricles are going to what? They're going to repolarize. So you can see everything forming nicely. Here we have kind of like the combination between leads 2 and 3. So we can see that it almost looks identical, almost. So it's kind of like you're combining leads 2 and 3, and this is what you get. You get the augmented vector foot, and you see it's very nice and clean and uniform. And you can see kind of like the picturesque, perfect EKG within V3, V4, V5, V6. We have kind of like this. We have the T wave right here. We also have the P wave right there, the QRS to QRS complex, and again the T wave. Notice that you don't really see this in V3 or V1 or V2, and that's okay. That's perfectly normal. In fact, you wouldn't expect to see something like V3 and V1 and V2. Totally fine. Also, you would expect to see something that looks really nice as an EKG in leads 2, but you wouldn't really expect to see T waves in leads 3. You can see a T wave right here. T wave. Do you see a P wave? P wave is right there. And so it is easier for you to look at an EKG that is perfectly normal and to say, hey, okay, this is a normal EKG. And then when you see something that is abnormal, something that is completely different, you say, hey, something's not right. Let me bring this to a doctor. Let me bring this to a nurse. Let me bring this to a cardiologist. And then they can look at it in detail and help you out. Typically, in a myocardial infarction or a heart attack, we're going to have some level of elevation. Specifically, we have a level of elevation in the ST wave. So we have ST elevation, and we have the myocardial infarction. So look what we just spelled. We just spelled STEMI. So that is an ST elevated myocardial infarction. Sometimes you can have a heart attack without having this ST elevation. In that case, we would have a non-ST elevated myocardial infarction. And so when we're learning about MIs in the EKG, this is what I'm looking for. This guy right here. And sometimes we're going to have this little slope where you do this. That's also abnormal. This ST wave is also abnormal. So it's like this sloping, and that's not good. So it's kind of like a red flag when you're looking at EKGs saying, hey, something's wrong with this guy's heart. Let's take it to a doctor. So here we have an EKG, and we can kind of see that everything looks kind of weird. So what's going on? First, I'm going to be looking at the leads 2, 3, and AVF. That's going to be the inferior portion of the heart. So let's see if we have any ST elevation. And here we have the ST elevated. So instead of doing this right there, we now have this elevation like that. So that is an ST elevation. So we have it here, here, there. We can really see it over here. So we have this ST elevation. Let's look at the augmented vector foot. Again, we have this ST elevation. Do we see this ST elevation in V1 or V2? Not really. I mean, you do see kind of like a little slope, which I don't like, but we don't have any elevation in V1, V2, none of that. We do have a little bit of elevation in V3, but it's not too bad. It's not like, it's just a little prolonged. So overall, it's fine. V3 is fine. V4, V5, V6 look clean, although you are missing a few little waves right here, little T waves. So V3 looks fine. V1 and AVL, let's look at that one. That's going to be the high lateral portion. of it. We have some depression right here. So for some reason we're depressed. We have this weird slope going downwards like that. I don't like that. And we really see it in augmented vector left. So we see it here and there and there. So what is this called? Well, first we have to figure out where it's located. We have a heart attack going on, but where is this located? Again, leads 2 and 3 and the AVF, that's going to be showing the inferior portion of the heart. And so we can call this an inferior myocardial infarction. And that is STEMI. So that is ST elevated. And we do see that we have this dip in lead 1, and it's even more dipped in the AVL section. And therefore, that is the inferior MI with reciprocal changes. So reciprocal. So it means that it's going to be even more worsened in the AVL with reciprocal high lateral changes. So if lead 1 is dipped, AVL is going to be even more dipped. So it reciprocated this change in the lead 1. All right, so here we have another EKG. And again, we're going to be looking at the IC all leads acronym. So we have the ISAL, so that's going to be the inferior. We're going to be looking at leads 2 and 3 and the augmented vector foot. So is there anything wrong with leads 2 and 3? No, looks pretty clean, looks pretty normal. Okay, what about the augmented vector foot? Looks pretty standard to me, because you have kind of like this little T wave, or this little P wave, sorry, and then goes in QRS, T wave, P wave, QRS, normal. Then we have the P wave, QRS, a little bit of T wave, P wave right there, which is fine. Same thing with the lead 3. So we have the P wave, QRS, little T wave, P wave, QRS, little T wave, etc. So pretty normal. So nothing wrong with the inferior portion of this section. So now we're going to go into the septal wall. We're going to go into the ventricle walls of the heart. So that's going to be in leads, or sorry, in V1 and V2. Here it's a little different. They just named it differently. C1, C2. It's fine. So automatically what I'm looking at is I see ST elevation. So we have kind of like this little dip right here and go like that. This portion right there, let's use a different color. This portion right here is STEMI. So that is a STEMI. We have an elevation on the ST portion. So we have STEMI right here. We have another STEMI right there. STEMI. And you can really see it in leads, in V2. Sorry, not leads. So right here we have STEMI right there too. And typically when you see them in pairs, when you see V1 and V2 having abnormalities, they are paired together. So definitely something is going on in the walls of the ventricles. What about V3? So V3 also has STEMI. So we have STEMI right there. So we have ST elevation. Is it also seen in V4? No, it's not. So we don't have any ST elevations. We actually have a depression. So instead of seeing this guy right here, instead we see this guy. So we have QRS, and then so notice that we have this dip. So this dip, or the slurring of a S, so we have a slurred S when it's like this, and it's trying to go back from the QRS complex. There's an abnormal dip. It's not supposed to be here. Focus on this section right here. Notice how there's no dip. Now notice how there is a dip, very large one, on V4. So the slurred S represents tissue damage. So this is actually tissue damage. And what we call that is actually called ischemia. So that is ischemia. And you know what? That's a bad color to write it in. It's a very bad color. So we're just going to put ischemia. And that is better on the eyes. So again, when we have this slurred S, we're going to have tissue damage. The tissue is not receiving oxygen, it is getting damaged as time progresses. We also have ischemia here, and yeah, some dipping of the S right there. Do we have that on the high lateral? So the V5, V6, that's the lateral portion of the heart, while V3 and V4, that is going to be the front of the heart. So that's going to be kind of like the anterior portion of the heart. How about the high portion of the heart, the high lateral? Do we see this? Oh, we have some dipping of the S right there. So that is ischemia. So we have tissue damage from lack of oxygen from this heart attack. And let's look at the AVL. So leads 1 and AVL are always together. And we have kind of like a little dip, the slurring right here. If we focus on this portion, we have this little slurring of the S, and not too much of a QRS complex. So what would you call this? We'll notice that a lot of the abnormalities are occurring in V1 and V2. And there's a little bit of well, not a little bit, but there's also STEMI in V3. But it's not present in V4, so that's different. Well, if they're paired together, there's definitely something wrong in that region. There's something wrong within the septal portion of the ventricles. However, V3 is not paired with V4. You see a STEMI in V3, but you don't see a STEMI in V4. Why is that? Well, let's pull up a picture. The reason why is because in V1 and V2, which is this portion right here, we have a heart attack going on. You also see this in V3, which is kind of like in the lower portion, but you don't see it in V4. V4 would be this portion. You don't see it in that portion. However, you do see tissue damage. In fact, you see tissue damage as a result of the heart attack occurring in V1, V2, and V3, and you see this tissue damage occurring in V4, V5, V6, and also the high laterals, V1 and AVF. So as a result of this purple heart attack going on in leads V1, V2, and V3, we have this tissue damage called ischemia, the lack of oxygen inside the tissue, occurring as a result of this heart attack in V4, V5, and V6. And so we would call this heart attack a septal. This is a septal myocardial infarction with ischemia to V4, V5, V6, and the high lateral portion. And the only reason why we call it a septal MI is because we have both the pairings of V1 and V2. That's called the septal portion. We don't really name it septal atrial or septal anterior because, well, we don't have V1, V2, V3, V4. We only have V1, V2, and V3. So because V3 is only paired by itself, we kind of ignore it. We acknowledge that there is damage within V3, the anterior portion, but it's not the full anterior portion. It's only partial for the anterior portion. And so because we have full damage within the septal portion, we call it the septal myocardial infarction with ischemic damage to the V4, V5, and V6. So to the lateral and high lateral portion of the heart, and a little bit of the anterior portion of the heart as well. Here we have another EKG. Again, we're going to do the acronym. We're going to do the I, C, all leads. So we're going to do the inferior. That's going to be leads 2 and 3 in the AVF. Anything wrong with this? Well, not as high as I like it to be like that. But, I mean, we'll take it, whatever. Same thing with leads 3. Other than that, we have the T wave, we have P wave, QRS complex, a little bit of some slurring. That's, okay. And over here, we look at the AVF. Well, not that much of a slur. So we don't have that much ischemia going on yet. Let's look at the septal wall. So that's going to be V1, V2. So let's see anything wrong with this. Oh, I see some ST elevation. So we are dealing with a STEMI. Now we have to pinpoint where this STEMI is located. because we have some ST elevation. The STEMI is also located in V3. So V3 and V4 are going to be part of the anterior portion of the heart. So that's the anterior. So we have STEMI right here, there. So ST elevation, there. Do we see it here? We do. So we have some ST elevation on V3 and V4. So for sure the anterior portion of the heart is damaged. Do we see that in V5 and V6? For sure we do. So we have ST elevation there, and ST elevation here, and there too. So V5, V6 would be the lateral portion or the side of the heart. Now we go to lead 1 and the AVL. So that's going to be the high lateral. That's going to be like the upper high portion of the heart. So do we have anything here? Yes, we do. So notice that we have this little bump and then a ST elevation. So yes, it's present here. And for sure, it's present right here. So STEMI. So notice that we have some ST elevation on V2, but not really on V1. V1 is just kind of like, you know, it's fine. Not really fine because there's a heart attack going on, but still. You see a lot of the ST elevations occurring in the anterolateral portion. And in fact, out of the 4 lateral portions, so V5, V6, lead 1 and AVL, those are actual lateral portions of the heart. They're all affected. They're all affected. And because the high lateral portion is affected as well as the lateral portion of the heart, this is actually called a high lateral MI, and it's also affecting the anterior portion of the heart. So now a lot of the heart has been affected by this heart attack, and if we don't treat it, this heart attack will start cutting off the oxygen supply to the other portions of the heart. So now you're going to be seeing some slurred S's right there. So you're going to have something like this on V1, and eventually you're going to see the same thing on V2 if we don't get this person to a hospital. And here we have our last EKG practice. So again, we're going to do the ICL leads acronym. We're going to do the inferior, the septal, the anterior, and the lateral portion, and then the high lateral portion. So we're going to start with the inferior. That's leads 2, 3, and AVF. Notice that we have some elevation right here. So instead of doing this, we are now doing this. Okay, so we have a red flag here and there. What about here? I mean, yeah, a little bit. I mean, not really. So we're just gonna kind of ignore this. But notice down the AVF, we do have a little bit of elevation here, right there. I guess you could argue that there's elevation right there, in here. Now we go into the septal region. So that's the wall of the ventricles. We have some elevation here. We for sure have elevation on the V2 right there too. So we are impacting the septal portion of the heart. Let's go to the anterior portion, to the front of the heart. We have ST elevation. And what about V4? ST elevation right there. What about V5? There is some elevation right there. Okay, so notice if you zoom in, we have more elevation. And V6, again, that's going to be some elevation. Ooh, this is not looking good. What's going on here, right? So we have some elevation on the high lateral, that's lead 1 and AVL. The lateral portion of the heart, the side of the heart, was V5 and V6. And again, you're going to have, I guess, a little bit of, you know what, let's just kind of leave that alone because it's, yeah, you know what, yeah, it is a little elevated. So in virtually almost all of the sections of the heart, we have ST elevation. And you might be thinking, oh, this is a massive total heart attack. And actually, this is not a heart attack. This person does have chest pain, but instead it is actually pericarditis. So it is the inflammation of the pericardial sac around the heart. So there is globular irritation of the heart. So everywhere you look in the heart is inflamed and irritated, and it is in pain. So when the heart is in pain, it's going to have all these signs that look like a heart attack. But when you see total ST elevations all over the place and you're freaking out, just think in the back of your mind, this may be pericarditis. It might be bacterial pericarditis, it might be viral pericarditis. But what I do know is that this may be pericarditis. This may not be a heart attack, because we have globular irritation, globular ST elevation within all leads, within all VIs, or V1, V2, V3, V4, V5, and V6. So that's just something to look out for. And that is the end of our lecture video. So hopefully now you understand the basic anatomy of the heart, the conduction system, the cardiovascular cycle, how to read EKGs very basically. Okay, so don't expect anything out of that, I guess. Hopefully you understand heart sounds and murmurs and the systolic and diastolic and all that jazz. And I've been recording for the past 6 hours. So that's great, because I have to set up everything and do further research and further studying when I do these videos, but it's great because I love what I do. So thank you so much for allowing me to be a part of your education. You are awesome, and I love you so much. The greatest gift that anybody can give to another person is an education, and I hope that I'm doing that for you. So thank you so much for studying with me, and I love you. And you're awesome. You're going to do great. Bye.